Chronic inflammatory diseases of the upper airway include allergic rhinitis and chronic rhinosinusitis with nasal polyps, or CRS-WNP, and chronic rhinosinusitis without nasal polyps, or CRS-SMP. In support of the unified airway theory, and as with asthma, sinonasal inflammation is thought to begin at the airway epithelium. In patients with CRS, microbes are more abundant and less diverse than the microbes found with normal colonization. These microbes enter a disrupted epithelium more easily and trigger a dysregulated immune response. This cascade may be partly induced by interferon gamma and IL-4 disruption of tight junctions, along with participation of inflammatory cells such as eosinophils and neutrophils. Environmental triggers can lead to the activation of epithelial alarmins that may activate innate lymphoid cells, or ILCs, in an antigen-independent manner. T cells are subsequently activated and can differentiate into Th1, Th2, or Th17 cells when activated by IL-12, IL-4, or IL-6 respectively, as well as other cytokines. The adaptive immune response initiates when T cells are activated in an antigen-specific manner and communicate with B cells for antibody production. ILC2 cells and Th2 cells are the main cellular contributors to type 2 inflammation, characterized by the release of IL-4, IL-5, and IL-13. IL-5 drives eosinophil differentiation, recruitment, and maturation. IL-13 activates several cell types important in mucus production and remodeling, two key aspects of CRS-WNP. IL-4 and IL-13 are responsible for isotype switching of the B cell towards production of IgE, which binds to its Fc receptor on the surface of mast cells and basophils. When exposed to a specific antigen, as in the case of allergic rhinitis, these IgE molecules and their receptors cross-link, leading to cellular activation and release of leukotrienes, prostaglandins, and type 2 cytokines. Ultimately, tissue remodeling from the inflammatory cascade leads to polyp formation, goblet cell hyperplasia, and increased permeability from epithelial barrier disruption. Polyp formation may also be driven by TPA inhibition and cross-linked fibrin mesh deposition. Inflammatory pathways leading to activation of Th1 and Th17 cells associated with type 1 and type 3 inflammation respectively are more often associated with CRS-SMP. The type 1 response is physiologically designed for host protection from intracellular microbes by activation of multiple cytokines and inflammatory cells. The type 3 inflammatory endotype is directed towards extracellular bacteria and fungi. Emerging evidence suggests that when polyps do occur in type 1 inflammation, they are composed of a fibrin matrix similar to that seen in type 2 inflammation.